Or you've had it for like over a week, haven't you, Alex?
Yeah. It's been since Tuesday.
I just emailed everybody. I just emailed everybody the link, so I'm gonna hang out for another like couple minutes and see if I don't know what was going on.
Hey, we got a third screen up on the TV tonight, or on the table here, because Michael Johnson, he's pacing the 5K, the Drake relays tonight.
Oh, really? Nice.
Yeah. I told him we just need you around 4:30. I can do that.
All right. Good for him.
He's only got to go through 2K though.
Yeah. So that's pretty cool.
Yeah. They originally asked him to do the pro 5K tomorrow. He was like, what? He said, yeah, they want to go out slow, just like 4:25. He said, all right.
It's super slow.
He said, I could probably do it. It won't be easy.
Pedestrian, if you ask me.
That's right. How's your running going there, Seth?
How's my running going?
Yeah. Well, besides COVID.
It was going good until I took all right, Alex, you don't have to mute yourself. I'm hearing myself for a third time. Sorry. All right, so we were doing good, and then I decided, I'm going home to see my parents tomorrow. I'm getting on a flight. So I decided to try and give my body as much possibility of not being contagious as possible. So I didn't run past 3 days.
David Goggins would vehemently disagree with your course of action to get rid of a disease. You should torture it. You should run as much as you possibly could. Not eat, probably stay up all night. So, well, do whatever you think's best. I mean,
What's your thoughts?
I'd drink a little gasoline.
Drink a little gasoline.
Yeah, you gotta kill that stuff, man.
We just throw some bourbon on it.
We got 2 full things of whiskey.
Is it good whiskey or just okay? Because coronavirus really thrives on bad whiskey, so it's got to be good.
I mean, it's for reserve and.
Come on, that's decent. That's decent.
Yeah.
All right. We got a small crew, but we'll get going. And I think for better or worse, because I had a couple people get a hold of me, I think the fact that I'm putting up recordings of these lends people to be like, oh, I don't need to show up. So I may not put up the recordings of the grand rounds, which kind of sucks, but I might just do that so people participate because it's more fun if more people are here. So, because 3 people messaged me before tonight and were like, hey, these are recorded, right? And I was like, yeah, but no, whatever. So let's get rolling. Let me share my screen. And let me see real quick. So Caleb, it was you that asked the question. So I'm glad you're on here because we're going to roll through a GAIT analysis, do a little Q&A. I'm going to answer your question, Caleb. And then we'll talk about there's not a whole lot of people on here, but see if anybody wants to go over anything out the authentic branding talk, or if anybody watched that or has questions. So I'm going to paraphrase because also Caleb's driving, but if he wants to chime in and correct me on anything on his question here. But, well, first of all, Caleb doesn't have a C. Alex, did you get your CSCS?
Yeah, good.
So Caleb basically asked, should he get the CSCS? He's tried to. He's wanted to work with athletes. He was wanting to know if he should get that or invest in something more along the lines of DNS or, another seminar. Also said that he may try to get a training job after try 3. So that would obviously be a correlate to that. And I thought this would be a better venue to answer that just because I'm sure other people have the same question. So Alex can chime in here as well, but the test and the information that you get tested on the CSCS is, for the most part, not great. right? It's pretty archaic. It's old school strength training principles. Some of it's good. Like some of the physiology on like dehydration, concussion management, on field stuff is not bad. But when it comes to actual training, which is kind of funny that the strength and conditioning part of it is pretty archaic, and they're literally just looking for the answers that they want. So that being said, like to me, it's kind of like a lot of the diplomate programs, like the certified chiropractic sports physician, which I have. Like it's not great material, right? But it's like, what doors does it open? So that 300 hours that you have to take for that diplomate is not by any means any better than any class you take at Logan, even though it should be, because it's postgraduate beyond, it's double postgrad if you're in grad school. But it's just not that great. And I got lucky that my master's degree at Logan allowed me to take the CCSP exam, the CSCS exam, and I could sit for the diplomate of ACBSP if I wanted to, just for that, which they stopped doing. So if you had the opportunity like to do the master's program and then take all those tests, I would 100% do it. Because then you can, if you want to go work in the Olympics, do an Olympic, training rotation if you want to do something at university. And that's my one knock on the CSCS, which I didn't renew mine. I'm not going to do the NASM renewal and all that stuff anymore, for the reason that I don't think they also uphold like the best continuing education thing or classes, right? It's not like chiropractic does either. They just allow you to take some, online stuff at the end of the year if you haven't got anything done. But what I started to see happen in the field, and I'm sure you guys see this too, is like a lot of people wanted to get the CSCS for a communication piece because they thought that like if they had that, people would be like, oh, they're a strength and conditioning coach too. Well, I can guarantee you somebody like Rich Olm, who was a strength and conditioning coach before they went to chiropractic school, would tell you that if you haven't been in the throes of, in particular, like a collegiate strength and conditioning program, planning and programming for multiple athletes in multiple sports, and then having to pay attention to their diet, lifestyle, all these things, like you shouldn't call yourself a strength conditioning coach. Right. And we may say, well, you don't have to be in that realm to do that. You could do it, one-on-one with your client base. Sure. But then do you have to have that CSCS, right? The CSCS is what the NCAA makes somebody get to get a job at a college. And when something becomes necessary to get a job, but then the education platform that it's built on isn't great, that's where I got a problem with it. So all that to be said, Alex kind of asked me the same question before he did it. And, I kind of came around to it. Really, it ends up being what your goals are of what you want your practice and time in school to look like as far as jobs that you can get and things like that. But Caleb's question, or the flip side, was, well, should I invest money elsewhere? I would say 100% yeah, especially when you're in school, right? You can get plenty of jobs. I would almost challenge you to think of a job that you would need a CSCS that you would be able to hold while you're going to Logan, right? Like anything that you think you would get with that, I guarantee you get with your super low level NASM, ACE personal trainer certification, right? I can't imagine anybody requires at any level a CSCS, because it's just not something that's required outside of a collegiate field for the most part, or professional athletics. So I would invest in, DNSA. So if you haven't taken any DNS, make sure you're doing that, so you have some lens. And then from there, MPI and McKinsey, get some of that stuff under your belt early. So yeah, invest the money elsewhere while you're in school, unless you absolutely know that you're going to go coach in more of a professional fashion. And that's not just like something to tack on to the end of your name. So beyond that question, I don't think anybody else is trying to get in here. So do you guys have any more questions just in general? So I wanted to kind of open up a general Q&A. It could be literally about anything before we get into, we have a kind of a case GAIT analysis and then some other stuff. So any questions in general besides COVID tests?
Yeah, I had a quick question. You talk about DNS. So I'm looking at like taking courses, but they're kind of like split the rest of the year. I think the only one that'd be like a somewhat introduction would be DNSB. Do you think that'd be too much to take? Like my first one, would you recommend just DNSA or a specific course?
So correct me if I'm wrong. Did you just ask if you can take DNSB before A, or that's the only thing that's available?
Yes, like would you recommend taking B before A? That's what I'm asking. Yeah.
Technically, you're supposed to take A before B. Like if you want to go through the track, like it used to be that they wouldn't let you take B without taking A. They don't really monitor it because each DNS class is monitored by the host now. So like if I hold a DNS class, I can literally say anybody can come. The problem becomes if you want to take that test. So if you do B before A and you want to take the B test, you can't because you have to take the A test first. And then they're not super easy tests. So if you take B and also there's a timeline on the test. I don't know what the timeline is, 3 or 6 months, and then you can't take the test. So you got to think about that too. Like if you're wanting to get certified, you have to take the test in a certain time frame and then pass them, obviously, and then you have to do them in order. So that's also kind of a thing to look out for. That you can do it. The other thing is like see if there's an exercise course, because those don't have to go in order. You don't have to have really any credentials to take an exercise class. So that could be something to look at too, which is DNSA and DNS exercise 1 are almost identical, right? It's just a little less hands-on with exercise 1, but in general, they go over all the principles. They say it's toned down for the trainers and coaches. It's really not. They want you to understand just as well as a physician, right? So being a practitioner, I would highly suggest doing them in order and taking the test, because you never know. You kick yourself 5 years from now if you didn't do them in order and take the test. You're like, damn, I wish I would have gotten certified so I could go to Prague or whatever it is. So yeah. And if it's not available, just invest in something else. Do some MPI seminars, which I highly encourage is to try to, do McKinsey if it's around, stuff like that. What other questions we got? And I'm mowing on Swedish Fish. So I have a 19-mile race kind of tomorrow. So.
Hey, Caleb, I know, so I'm just looking on just Stott's website. They've got not much for this summer other than DNSB, but they're doing DNSPEDS 1 and the TMJ course in the fall. And those are at Winchester's, but then there's also MPI PEDS this summer too. And I thought weightlifting was this fall, but I could be wrong.
Well, and I know you're in St. Louis, but we're having Ulm teach exercise 1 at our place in September. So, that is coming to us. So that's available, but it's all, can you travel? And then A will be back at Winchester's in January of next year, I believe.
Okay, yeah. Kind of say he just had it like last month, so
yeah,
probably would figure he wasn't gonna be around soon.
Yep. Anything else?
If you want to get in on a running seminar, we might have one coming in September. Yeah.
Yeah, we got to get.
You talked that.
CEU's got approved, so now you get Chiro CE.
Okay.
You got all that stuff. Yeah. So.
Sweet. I haven't seen Breaker in a little bit because, Kaylee.
You haven't what? Sorry, it was like.
I haven't seen Breaker in.
Oh.
Sorry. Yeah, gotcha. I haven't seen Breaker in a little while because we were going to talk about it, but.
Yeah.
We just been talking about singlets lately.
Yeah, no worries.
There's a solid seminar I know coming up in Wichita.
Yeah. That'll be a good one. Why not go to Wichita?
I can't remember the name. Can't remember the name of the guy, but
something RX.
I think it's pretty sweet.
Yeah, I heard he's full of shit though. But I don't know. We'll see.
He's just getting old, so he might have a little bit of old school ways, but still.
Yeah, he's probably got dementia, so hopefully he takes his medication.
He probably has dementia.
Yeah.
To be fair, said we weren't the ones that could get on Zoom tonight.
Yeah, Caleb got on fine, so I'm putting that one on you guys. And he's driving, and he did it from his phone, so yeah.
COVID messes with the head. There's just something about it. Just haven't quite figured it out.
Well, I'll Gmail links out the day before instead of using the farm email, because that seems to go through from mine. So I'll just do it all as normal and then get it out. All right. If you guys got more questions, just stop me because it's just us tonight. So let me get back over here. All right. Case number 1. So this is a fairly new case. It's just about 3 weeks old. Come on. That's not supposed to be there. We'll come back to that. So 45-year-old male, chief complaint, extreme calf tightness / pain only when running. This has been going on for quite a while. So he started running about 6 years ago to lose weight, get in shape. He's a little heavy set now. We'll talk about that in a second, but he was a fairly athletic guy in high school. Took a lot of years off in the middle to go work and have kids like a lot of people do. And then tried to get back into it with running. And he said, when he first started running, started having a lot of foot pain and both feet. And he was just like, it got to the point where it was like literally killing me. So I went to podiatrist got him orthotics. It's like, my feet feel awesome. Well, it wasn't too long after that his feet stopped bothering him. And we'll talk about shoes here in a second, but that's when the calf tightness, and we're talking like anterior, posterior, sides, like would get worse and worse and worse to the point where he would have to stop running. And we're talking like tops 5 miles before he's literally in excruciating pain. But as soon as he stopped, it dissipated. And then he may be sore the next day, like like muscle soreness. So beyond the podiatrist, then he went and did 3 separate trials of physical therapy. Also a note with those orthotics, they also put him in a motion control shoe, which is a huge no-no, in particular with somebody that's running. Usually we try not to get people to run an orthotic, but if you're going to put something in orthotic, you usually don't put them in a motion control shoe because it's just too much. And you have to let the orthotic do what it's supposed to do. So if you're trying to control motion with the shoe and the orthotic, it tends to kind of backfire. So he's done physical therapy. So it's not like he hasn't tried to work on, well, who knows what they wanted to work on at that point, but something, trying to change function, address something beyond just orthotics. And I didn't put this in here, but he did 2 rounds of cortisone injections in both calves, which I don't know. That was via the podiatrist. Don't know what that was supposed to do besides just, I have no clue, make somebody money. But then he received a different pair of orthotics from a second podiatrist after physical therapy, right? And this is 3 separate trials, 3 months physical therapy doesn't get better, goes to somebody else, then he goes to get a podiatrist. No change in symptoms beyond that, but he was still using the second pair of orthotics when he came into my office from 3 years ago. And then as of 6 months ago, because COVID happened, he put on some weight. He wanted to really start to try to get to running because he was feeling a little bad about himself. He's like, I would get a mile in, it would be excruciating. Like he would have to stop. He's like, I'm just over it. I want to run again. I'll do whatever I need to do. So he went to an ortho before he saw me, and they diagnosed him with chronic exertional compartment syndrome. And the ortho even told him, he goes, I really don't know what's going on, but this is the closest thing to what I think you have, which is kind of like, oh, cool. Thanks. So I guess it's now diagnosis by proximity rather than specificity. But that's what he walked in with. He's like, this is what I've been told I have. This is everything I've done. What should I do? So on exam, dysfunction on painful on everything except bilateral upper extremity pattern 2, right? Reach behind your back, touching your shoulder blade, over the top of your head, touching your shoulder blade. But even though all these are dysfunctional and painful, they're still pretty good. Right? Nothing's terrible. Like this guy is pretty good. Like he can touch his toes, just non-uniform curve, right? Like that kind of stuff. So he moves fairly well, and he's more on the flexible side in general. Walking gait analysis, bilateral ankle valgus, right? So he's spilling into both ankles, which in essence helps create that foot flare because now he moves more through the inside of his feet. So you could start thinking, well, oh, that's, this functional thing is going to lead to, weird loading through his feet and his calves, and then bilateral hip extension, which all of those go together. If you see one of these things, you're usually going to see the other things correlated with that, right? This guy has bowling balls for calves. I mean, gigantic. I don't think he can wear jeans because he wouldn't be able to get him over his calves. Huge. And he's a pretty stocky guy. You're going to see his gait analysis here, but big calves. Bigger than my wife. And she would tell you hers are pretty big. Better than average intrinsic foot control, which I was surprised by. Having foot pain, starting running, being put in orthotics, wearing a motion control shoe. By the time he came into me, he was wearing ultras just around because he found out those felt better on his feet. But he could do some minimal toe yoga stuff, right? Back and forth. He could control it pretty well. So he has decent movement. He's more mobile than not. He has good intrinsic foot control. So we're starting to kind of lean more away from like an injury and more into like the skill subset. Left hip extension restriction. And that's really the only thing that I found that I was like, man, this is really a true like mobility issue. The other interesting note is if we had him prone and took him into left hip extension, he got a little bit of low back pain. And that's when I started asking, well, do you deal with low back pain? Because he never mentioned that in his history, no low back pain, you know, in top tier analysis. He says that he does have some low back pain when running, but again, that goes away when he's done running. So he didn't think anything of it. And then getting into it, poor intra-abdominal production, a little bit of a diastasis, more where the diastasis is just around the upper rectus abdominis and not kind of down the whole linea alba. But really hard for him to, well, we'll talk about that in a second, but diastasis, he could actually hang out in a dead bug, not too bad. He could create intra-abdominal pressure, decent, but it wasn't awesome. And then he could breathe like into his belly. So it wasn't terrible, right? It's just, he couldn't put a lot of these things together for a long period of time or at a high threshold. And then one of the bigger findings, I'll go ahead and like give you a little clue, is this TL junction extension restriction. All right, he's a pretty flexible guy, but that's just kind of just stiff as bricks on him. And then he's got a stiff T-spine in general above that, but that TL junction thing is going to come back to haunt him. So let's look at his running gait, because that's part of the exam. Now, if you've heard me talk about my examination process, we rarely even do a running gait analysis at all. So for me to do a gait analysis on somebody on the first day, you got to think that I am definitely, see if I can get this to happen. I'm definitely thinking that there's not an injury going on and that we're probably dealing with some sort of running, you know, issue, something we may be able to coach around a little bit. So that is rare for me to get into that. So let's blow this up a little bit if we can. I think that's big as it's going to get. So I'm going to let it play. And I know, well, actually I probably won't, because I don't know how jerky this is. This is at half speed. So it's as jerky on my screen as it is for you. So I know it's stopping a little bit. And I'll pause at certain points. So let's go ahead and do this. And then we'll kind of freeze frame some stuff. So if we watch this guy, and it's good to watch him from the waist down here, and this is something that sometimes you need to cut people's bodies into parts rather than watching the whole thing. So first of all, what's one of the big things we look at on gait analysis? Where's the foot at impact? Way out ahead of his center of mass, right? Like quite a bit. If that's the center of mass, that's his ankle. Now, here's an extremely interesting thing. He somehow, remember how I said he's pretty mobile? He's manipulated his foot into what? A full foot landing, even though it's 12 degrees out in front of his center of mass. What's his big complaint? Calf, like anterior, posterior, side to side tightness. What do we already see that he's doing? He isn't even eccentrically letting his foot load into the ground, right? He's putting it down. Immediately what has to turn on? His gastroc, right? He hasn't used his anterior tib to slow down acceleration. It's literally just like, and then is going to start to go to stance phase. So if we clear that out, when we go, let's follow that left foot. Now, really key in on this. So let's get rid of that. Sorry. So I hope you guys can see this. Can you see that his heel isn't on the ground? So his heel never touches the ground, which again, seems impossible that you could reach that far out in front of you, full foot landing, which he's really more kind of 4 foot, 3/4, never lets his heel touch. So again, he's in ultras that are pretty wore out. Those are Escalantes. So he's in a neutral shoe with a moderate amount of cushion, and his heel never touches the ground. So again, gastroc is just loaded. Gastroc soleus complex, right? Together. Zoom out, kind of keep going. Let's watch the right foot. Right foot comes in real hot, right? That's a lot of heel stuff. And what did we note on his left hip? Left hip extension restriction, right? That caused low back pain when we went into extension. So what are we starting to think, or what am I starting to think? That his dominant side is his left side, right? That he would rather kind of control everything through there. There's a lot more impact being driven up through his hip. His way of accommodating for that is stiffening his hip up. And then he's just kind of manipulating that side because of who knows why. Like that's a question I don't know if we could answer. So obviously we're out in front of center of mass, right? He stays up on his toe. He goes through a decent toe off here, and then he's right back onto that heel. So his flight time, right, is not great. You seeing that? So what's one of our big indicators of injury? It's stance time, right? Or increased time, contact time, ground time, or ground reaction time. So now let's kind of try to cut him in half from the top up. So if we didn't see his legs in relation to his upper body, there's not really anything wrong with this, right? Pretty relaxed, good rotation happening around his torso. Hope you guys watched that rotation and running video I put up on YouTube. We talk a lot about this stuff. So now let's look at them together though. So when his foot lands, can you guys appreciate how much of an angle he is of hip flexion? Like he's hinging into his hip. Remember how I said he had that TL junction extension restriction? This is a really common thing you're going to see. And this is my opinion, right? That I see if you can't, the lumbar lordosis is a huge piece of the evolutionary puzzle that got us running, right? That we evolved that lumbar spine curve. We got upright, but that also allows us to translate rotational force through our pelvis, right? That spinal engine theory. If you lose extension, what do you have to do? Sit into your hip because you can't extend from your back, and then you push through your hip or your calf. And where's his ass? In that giant hypertrophied calf, right? It's not that his glutes are weak like everybody gets told when they're pushing with their calf. He literally has to use below the knee motoring, right? Kind of drive himself. So there's no hip extension on this left side. You seeing that? Like this is, I know it looks like his leg's behind him, but that is neutral because his hip is an anterior tilt, right? So that's neutral. And that's that hip that's stiff, but it's the same on both sides. He's just like hitting a brick wall there. And that's at like a 5.5 speed wise. So there's not a ton to see down the line. I mean, if you look down the line on him, it's pretty decent, right? He maintains width. He's got a little bit of a heel whip on this left side. You're going to see his foot going to that flare, right? So you kind of kick your heel in, not as much on the right. So here's an interesting thing. So did you guys, I know Seth and Alex were shaking their head. They watched that rotation running video. I went over this very briefly. The reason that Sergei Grekovetsky came up with the spinal engine theory is because he realized that you couldn't create torque into the ground with your foot very well, right? So he knew that you had to be creating torque in your body and then displacing that into the ground. Well, watch what this guy's foot's doing. It's like he's putting out a cigarette because it spins off the ground every time. You seeing that? And that one goes off his lateral side, which no bueno there, right? He's literally spinning off his like pinky toe. Woo. That's not fun for anybody right there. This side, he does a little bit better, but he's like creating torque. So you can tell that he's not transferring force from his torso to his hips to the ground. He's trying to create it at the ground. Again, where were his initial symptoms? His feet. Where did the symptoms go when the orthotics helped him a little bit? His calf. So this is what I am trying to teach people in this RX3 thing, right? Like if you understand physiology and mechanics and biomechanics and like neuromechanics in particular, you start to understand that, hey, anything that even seems like an injury still probably has a big precursory, issue going on. And it's just like if you don't understand how to hit a golf ball and you're working with a golfer and they're dealing with pain only when they golf, you may get them better, but I think you'd be much better suited to understand those mechanics a little bit better. So creating torque, and again, I can't really speed this up because it'll chop too much. But remember how I said his torso looked decent when you're just kind of looking above? Do you guys actually see any rotation happen in his T-spine? Or is it just shoulder blades in his arms? Just shoulder blades and arms, right? Which we haven't really addressed with him. But if you make somebody stiff in their TL junction, what are you robbing them of? Ton of rotation, right? That's where upwards of like 45 to 55 degrees your rotation comes from, is like TL junction, at least in the thoracic spine. So that's his GAIT analysis. Let's book out of here. Sorry, I'm reading Caleb's message. All right. So you guys can see my screen again, right? Good. So like I said, this is a research article I'll be putting out probably next week, but this just came out, I think 2 weeks ago, talking about that contact time and how in elite runners, that was one of the biggest predictors of injury was, right? If you saw an increased contact time, in particular, asymmetrical contact time. So if like a left leg's on the ground longer, and that's the kind of thing, like I've said this before, like we don't have that equipment in the office, but if I worked with 80% professional runners, you would want something like OptiGate to see contact times, right? Vertical oscillation, flight. So you can kind of like normalize data, just like a golfer, right? Like an amateur golfer doesn't get a whole lot of out of a TrackMan session, like all the flight angles, attack angle, like they need to hit the ball better. Most people just need to run better. But if you're a pro, then it gets into, okay, you're 60% of your times on this left leg, and that adds like, 2 milliseconds every time, which adds up to like 5 minutes of extra contact time. That can be a big deal for a stress injury. So needs-based assessment. I know this is yeah, go ahead.
So as far as that study goes with elite runners, would like the extra time that they're spending compared to the other runners that aren't getting hurt as much, is it just because their like capacity or their volume is super high compared to the normal runner? Because I'm sure their contact time is still greater than or less than most people's contact time.
So wait, say the first part of that.
Talking about people like the elite runners that are getting hurt, is their contact time still like that of a normal, just average Joe runner? Or is it just that they're running so much that it's slightly less than, or it's slightly more contact time than their counterparts? But
that study in particular looked at asymmetry. So like contact time, asymmetry left to right, but also if you took it's more of if you took 300 runners and saw, based on time, they're elite, they're not elite based on contact time. And then you took the people that were the most injured out of the 300, they would have the longest contact times. That's kind of what they're looking at. So your question's a good question, but it's more like, okay, now we're getting into, which also goes hand in hand with what? Cadence, right? Or turnover, which has obviously been looked at a lot. So that's kind of like, now we're going to get into this normative thing of like, what's optimum contact time? Man, that's tough, because then it's like, leg length, femur length, tibial length, all this stuff, like, I don't know. So that's probably a hard.
That's what I was kind of.
Yeah, it's a really good question.
Yeah, I was wondering if that's where that was going.
But I would say what are most of the elite runners that are going to get injured more? That's probably highly correlative to like an amateur runner, right? They just probably have a higher capacity of tissue tolerance just in general, which helped them be a endurance athlete, right? So again, it's not a good audit, but like he only has symptoms when he runs. So that's what we have to use as pain audit, right? There's no reproducible anything. Function, we could use running, right? We're not supposed to use functional audit and pain audit in the same, vein if we can help it. We could use running though, because there's things to work on in running. But with him, TL junction is a fixed point during 3-month supine, which I didn't go into depth on his exam for this reason. But he could get all of the parts relatively right. But if you really have him try to lock TL junction down onto the table and you'd be like, well, I thought he couldn't extend. He just doesn't. If you don't have good movement at a joint, what do you not have? Good feedback. So it's hard for him to create a fixed point, engage his lower abdominal wall and then create pressure. So the longer we kept him there, you saw his diastasis get a little more pronounced, start shaking. And then you see, okay, when he runs, where's he going to have a tendency to get his extension from? Above TL junction, lean into that diastasis, L5, S1, or, anterior pelvic tilt. And then that's why he has this hip hinge. He's like sitting backwards away from this like excessive kind of anterior pelvic position. So that's my functional audit. Can we improve his ability to create a fixed point and then start moving around there, which is low hanging fruit, but that's a good place to start. So diff die, it's not compartment syndrome. And the way you also know that, this is a good thing to discuss, which in part A of our X3, we talked about this, like his skin tone, right? It's not like he had high tension down. So it's not like there was a dysregulation of fluid. He doesn't have trophodema, right? The pitting of the skin, if you kind of push the skin around, which is indicative of basically fluid sitting within the fascial layers or in between the dermis and the fascia. But he also doesn't have anything that ever gets like debilitatingly tight, where he feels like his calves get tight, right? They just hurt. So he has no like issues with fluid regulation. So it's not compartment syndrome. You could call it anterior shin splints. That would just be calling it something to call it something, right? What we really need to think about is it just lower leg pain, or is it lower leg pain that's being exacerbated by this kind of low back, poor lumbopelvic central stability pattern? And that's what I would throw in there, is that we have some central disc derangement, spondylolisthesis, spondylosis, central canal stenosis that's really bugging him because he has some back pain. And then his needs-based assessment is basically improve central stability and then see if that helps with running and then the pain, right? Rather than thinking like we're just going to completely coach him into pain-free running. That being said, I did a GAIT analysis on the first visit for a reason, right? Because he basically checked all the boxes. Like I could put him in a Milgram's test. He could maintain. He could do all these things. Nothing created pain. We put him on the treadmill. It's not great. The reason I also gave him a couple coaching cues for running is he was about it. It's like his wit's end. He's like, I'm gaining weight. I'm getting depressed. I feel like I'm pretty young for not being able to run. I was like, all right, we got to get you to run. So my only coaching cue to this guy was, you have to think that somebody has a belt buckle or a rope attached to your belt buckle and they're pulling you forward as you run. We also broke his running into intervals, which you'll see here in a second. So from a treatment standpoint, obviously we get in there and blow up TL junction and T4 through T8. I'm going to skip this first part. So TL junction, what I've started to have a lot of people do is, I'm not a big fan of foam rolling in TL junction because it tends to, like, lumbar spine has a lot of extension. So I'll have them take like a yoga mat or a bath towel, roll it up, put it under TL junction and just lay over it and do like 20 belly breaths and try to get passive extension via something there, right? That comes from yoga. They usually put a yoga block that's aggressive, like really aggressive. So get something that gets, the induction of extension there. Just like if we sat there and pushed for a long time, that's a grade 1 mobilization, right? Just load. Beyond that, then we go into obviously IAP dead bug start position for TL junction extension, 10-month sitting rotations, TL junction, and then hanging was me trying to tie in TL junction extension with some of the foot mechanics stuff, because he does pretty well. We still got to tie that stuff in my opinion, like neurologically, right, for a strategy play. And like I said, run coaching, it was just hips forward. I hate coaching running. I think it's just it could be a surefire way to make him worse, right? If he can't extend through his TL junction, I tell him to push his hips forward further in running. What do we chance? Just making his back worse, right? Because he doesn't know, or he can't get there. So I knew that was a risk, but I also needed to maybe just give him some confidence, like, hey, if you do this, and also break your running up into intervals. So I had him do, no, I thought I put it in there. Sorry. 1 minute run, that could be whatever speed. And then he had to walk, jog for 3 minutes. And he could do as many of those as he wanted, as long as he didn't have pain. We did his first run like that, did 10 of them. So, I mean, that's, 30, 40-minute run or whatever, no issues. And then the next time he just went out and ran 3 miles, no symptoms whatsoever, like nothing. And he was just elated because he's like, I haven't run in 5 years without anything. The only thing I had him doing at home again was, well, I got to back up so we can see this. IAP, and we talked about that on his run too. Right? That like, you have to think about that if you're going to try to control anything. Dead bug and then passive extensions, like that's not a lot. So was it the run coaching? Was it that? Was it a confidence play? Who knows, right? It's really hard to tell. And I've seen him twice now, but this was the first follow-up. So no pain, soreness. Now he did say his low back got tight, right? And across the whole kind of lumbosacral junction. So when on that follow-up visit, we worked way more on TL junction extension. I did some dry needling around there, went in there and adjusted again. And I also went in there and again, tried to get him to establish like decompensation of him just loading his lumbosacral junction excessively, because in my opinion, he probably does have some sort of posterior cord compression from anterior spinal movement. right? And that's why he's getting these bilateral, just like really tight sensations. And then that's probably just exacerbated by running like that. Cause I've seen a ton of people run like he does that don't have the same symptoms. So it's not like those symptoms are a one-to-one of your calves blow up, right? His calves blow up because they're sensitive because he's pushing on his spine, right? Or spinal cord or the sac. And then he's running like that. And it's just like, again, too much. And then the homework after this visit was start position. So we started going after, once he's kind of got an idea like, hey, you need to really start working on this stuff, and we'll progress him into doing 10-month stuff at home and eventually doing some overhead work. So any questions on that? I know it's just you guys. You guys know a lot of this stuff, or should know a lot of this stuff. Stop sharing this, get us back over here. And then shoe wise for him, this is something I didn't cover in there. He was running in those ultras. I actually am trying to get him out of those, right? He really likes the width and everything, but he needs something under his heel, because what do we see on his gait analysis? Heel isn't touching. He needs feedback if that's the only thing it's for, but also just to get his foot to offload his calf, right? So he's not loading up that gastrocsoleus Achilles complex. I think if you do that, that's just going to safeguard him, so he doesn't show up with like really something going on when he starts running more miles. Like probably he's the guy that will show up with Achilles stuff eventually, the way he runs on his toes. And I told him, hey, if you run for 6 months and you feel good, you can go back to the ultras, right? But like, I just think that's a hurdle or a variable we don't need right now. Outside of that, yeah. Oh, we got obviously. So his second set of orthotics he came in with were foam. They had no hard, they literally were nothing. And I said, stand on those, and he just crushes them, right? And I go, get those out of your shoes. So we took those out immediately. I also had him, obviously go barefoot around the house, which he told me, he goes, well, my feet are going to kill me. When he came back, he's like, I was kind of surprised they're only sore for like 2 days and they're fine. I was like, yeah. So we did a little more than I let on there, but like, we're going to have to like monitor this guy, because he's the guy that's also probably going to go nuts, like 10 miles. And then he blows his calves up and he gets pissed. And, I really think it's a central stability game. That's going to be hard for him to like maintain, because he, does have some anterior adiposity and doesn't have great control, but he's also very like diligent and pretty aware of what we're working on. So we'll see what's going on this next week with him. But yeah, or actually I gave him 2 weeks because I wanted him to run more, and he did so well. What you got, Seth? You got a question?
Yeah. We were looking earlier at his thoracic rotation.
Mm-hmm.
Did any of that look like it got better the second time you saw him? Like, just because you worked on extension, did rotation get better, or were you working on just his hips for right now?
So we didn't, I didn't put him on a treadmill again, right? Like reanalyze, because I might do that later just to have something, but I wouldn't ever need to do that for my thing, right? If he's running pain-free, I don't want to mess it up by saying, oh gosh, you're not doing this. Now his, remember how I said like everything was dysfunctional and painful? His rotation was still good. It just wasn't great. So like he has rotation in his mid T-spine. It's just not awesome, right? It's not like he's just stiff as bricks, like 20 degrees. I would say he's just shy and it's just stiff. But also, why do we think he may be stiff in TL junction and his mid T-spine? He has diastasis recti, right? He doesn't stabilize very well. And that, in my opinion, besides early developmental, being sat up too early, losing TL junction extension, all that stuff, like that would be the huge, like the big play there, right? That's why right as soon as you see a diastasis, especially with somebody with bilateral symptoms, you're starting to think, cord compression, or stenosis or something. So with him, yeah, I'm not going to check rotation, because I guarantee you in 3 more weeks, if he really gets central stability down, a bunch of those dysfunctional and painfuls just go away. And then it will be interesting. I'll put him on the treadmill here maybe in a month and just see if he frees up, right? Because I think that's a big deal for him. And then maybe we do coach like, hey, just relax your upper body. Or maybe we do, coach a little bit of rotation into him. But somebody that's had so many problems, I want to really just try to, be more hands off and be like, just get back to running and see what happens. But that's a good question.
So you're saying like his thoracic like lack of extension was coming, I guess, like from like his ability to like stabilize, like while he was running, and like maybe be able to dissociate between like hips, pelvis running, and then like upright, like in his thoracic.
Yeah. Cause I mean, his
Okay.
diastasis may have come on later in life. I doubt it. Like, I think that's, actually, I'll look up the data on that, but I think that's a bit of a fallacy to think that adiposity, right? A lot of people get told like, oh, you gain weight, you put a lot of stress, like a pregnant woman, on the front of your stomach. It's like, I don't really believe that, right? The reason that women get it is what? It's not adiposity. It's a baby growing really fast that literally pushes on your anterior abdominal wall without any adiposity that helps create that. And then it also is a very different dynamic than fat. Because the thing is, if somebody is morbidly obese, why doesn't everybody that's morbidly obese get a diastasis recti? They don't, and that just doesn't make sense to me. So I think a lot of them are congenital, right? They didn't close that rectus abdominis wall when they should have. And then that leads to TL junction stiffening. They do that their whole life, and they just pick different options for extension. And that's the other reason I think his hip was stiff. His body's like, you're absolutely just going to destroy your back if I let you take your hip behind you. Right. So it's like stopping him from like lumbopelvic motion. Cause his hip was, again, I should have put this in there, totally normal the next time I saw him. Like it's a neurologic tension completely. And that's, again, everybody says this, but like trying to decipher if something is truly stiff or if it's neurologically stiff. And, if you think all these trigger points exist, like everybody says and everything, then like almost everything is neurology, right? Rarely are you going to get a tight joint, which, I mean, we're on here so we can talk about it. And Monica said she's going to watch after, so she'll love that I bring this up. But Monica and I got into a good little debate with Clayton Reuter, who's going to be our next intern or extern in here. He stopped by last Friday. But she was doing something with the girl's ankle, and he's like, well, why did you do FRC instead of something else? And she was like, oh, I don't know. It's a good question. And I was like, oh, you don't know why you did it? So we just, I was like, well, that is the question, right? Like, why do you pick something? Because it would be the most effective. But then if you did something and it worked, could you have done something else and it still would have worked, or would have worked better, or it would take less time, or whatever it is? So then we got into this debate that Sloan and I have had a couple times of like FRC principles versus DNS, right? The idea that if you get a joint working appropriately, that you have good feedback and that joint will play in the system well. I think that's complete bullshit. The reason being, if you get a hypermobile person, they have a joint that works really well. They have tissue that's more extensible than mine. That doesn't mean they can control that joint in space on its own or in a regional interdependent scenario at all. Now, the other flip side of the FRC argument there is what? Well, they work on end range control, right? Control yourself's their thing. Just because you can dorsiflex your ankle all the way, plantar flex your ankle all the way, in my opinion, does not mean that your ankle knows what to do when you load it with 3.5 times your body weight when you run. So then how's that get matched? Well, I would say DNS creates a better strategy. If you have a joint that works better, it's easier to utilize DNS. So if somebody had truly capsular tightness, I don't think DNS is the way to go, right? You got to get that joint working a little bit better to play into the system to have a neurologic input. But FRC would argue, if I'm like, well, you can't utilize that ankle in running like you should, they're like, well, if you get some fancy pattern, how's that correlate into running? Well, nobody taught any of us how to run, right? Like we all should have done it. We lost it at some point unless you had something going on. So if I tap back, if I have normal movement in a joint and tissue, whether I was established before or after I worked on it, and then I cue up patterns that you've done your entire life, like that should kind of follow into this pattern versus just saying, oh, your ankle works better. That works, right? Like you can go run, you can go squat. I just think that's kind of false because I don't think that's how the nervous system works. And that's, if you look at neuromechanics, which is what I'm going to try to take is Roger Anoka's book on neuromechanics and try to like bring that to the chiropractic realm, because it gets talked about a lot of like modifying your environment and then modifying the organism, but we never really actually address that stuff, that you're like, okay, your ankle needs to be able to do this. We tend to be like, oh, your ankle's working better. Oh, you can do like, I had a pro golfer that I did a virtual consult with yesterday, and he stepped in a hole during a tournament and blew his ankle out and ruined his golf game. He's a pro golfer. And he said that when Gray Cook presented his case, the World Golf Fitness Summit in 2018, it was such a bad ankle case, or good, however you want to look at it. And he said that Gray referred him to a PT in Orlando. So guy's got to be pretty good if, Gray Cook's referring people to him. And he said that this guy formulated a plan that because he could do a pistol squat on his right ankle, on his left, that if he could do a pistol squat on his right, that he'd be good to go. That makes no fucking sense. Like, A, it's a pistol squat. Why does a golfer need to do that? B, you don't know if his right ankle could do it before the injury or not, right? That's a superfluous movement to golf or life in general. So and then they followed that pattern and the guy still having problems, ended up getting PRP injections after this, still having problems. That's what I'm saying. So, what I told this guy, the only test that matters for you is, can you play golf? Can you score? Can you put the ball in the hole? Right? You could do that without an ankle. There are people that are doing that, probably better than you, that golfer. So I think we need to realize there's much higher fish to fry with audits if you're working with actual athletes and even people, right? Rather than us thinking we cleared your top tier SFMA or whatever objective we are at, functional, even the functional audit and the pain audit. That's great because that's clinical. But do you know that they can actually operate? I think that's where you start separating yourself. Okay, what's your goal? What'd you come in here for? How can I test that goal within my office as well as I can, or set up a plan for them to test it outside of the office in a smart way, right? Like how we break up running into intervals, or, if somebody, I'm going to do a case next time talking about a woman that had really bad crips, right? RSDS stuff that really bad, that she was told the day before she came and saw me that she had a 15% chance of never walking again. And then on top of that, this is what she was told by an ortho, that there was a 5% chance that she was going to have her foot cut off. That we know those are things. What the hell are you telling people that for? B, her goal on the end of this is not, does your foot feel okay? Because what do we know about something like crips? You go get into the similar scenario that happened before that may not even be the same, and it could just pop right. So guess what you got to do? One of her kids dropped a full Yeti jug on her MTP, first MTP on her foot, dropped it on, and that's what set all this off. No fracture, right? She had CT scans, all this stuff. But let's say that, I don't know, a year from now, she drops something not innocuous, right? She drops her phone, or I guess your phone could get you a wallet or purse on her foot. There's a high chance that it blows up. So as weird as it sounds, in the clinic, you have to mimic something for the end stage care for her, where you either really go in there and perturb that area. That could be needles, right? It could be something high level like that. It could also be something creative, right? It sounds weird, but what if you throw shit at her foot? I know you're oh, that's tight. She needs a threat dose response, right? And I was oh, my foot can take it. So I've got videos of some of the stuff I've been doing with her. That'll be a really interesting case to go over, because from where she came from, how fast we got her better, and just to let you guys in on it. I saw her for the first time, I think 3 weeks ago. She was on a scooter, right? A post-surgical scooter. She was walking up and down stairs today, and she'd been on that scooter for 2 months. So when you understand neurology and how stuff works versus just being the ortho or physician, whatever, doesn't matter what profession, that's just I think you got chronic exertional compartment syndrome. Oh, you have crips. There's all these chances of this really bad shit happening. And then literally just send her on her way. It's God. So yeah, it fires me up to think about those things, because we're the people that are doing that. And yeah, I don't think we get compensated well enough for what we do, because I think we're all going above and beyond. So another reason to do this residency, we need more people that are absolutely just killing it. And then that helps create a different I don't know the best way to say this, a different level of perceived need in the public, right? Why would that person ever go to anybody else again if you can do that for them, right? And that's what we're trying to build. I don't want people to come for back pain. I want them to come to me for everything. I'll refer you wherever you need to go, right? But don't go through the trouble of, that person with the crips went to 5 physicians, had a corticosteroid injections, just nothing, right, was helping, to the point where, major depression. So yeah, gets way outside of running, but those are actually the fun ones, right? It's really weird stuff that you can help, and some said you can't, but we'll go over that for sure. You guys know what I'm talking about with CRIPS, right? Chronic regional pain syndrome. It used to be called RSDS, reflex sympathetic dystrophy. Yeah. So it's basically where you get a initial injury, usually a crush injury, right? Something that doesn't necessarily, could break a bone, but really bad trauma. And there's thoughts behind why this happens, right? That maybe you damage like the intima of a vessel, right? Because it has a big vascular component. But basically you get an injury, and then an injury that should just heal, and it doesn't, because your body's stuck in this basically sympathetic loop that it thinks it needs to constantly keep you re-injured because something's not right, Threat. So it's a central nervous system problem. But the symptoms are swelling, your whatever's affected turns completely purple, skin starts to fall off like it's dead, right? Your body's trying to kill it. It's like a self-amputation, because it's like, you know how we say smudging, like cortical smudging, like you reduce the cortical image of something, it's that on steroids. So what would be the treatment? Dose response of increased afferent input, right? Reducing risk, blood flow, lymphatic flow, like that's all the stuff we did. And it was just like literally night and day. So yeah, we'll go over that next grand rounds for sure. I've got a ton of video stuff with her too. So it's kind of fun to look at. All right. It's been an hour. Any other questions about anything? I'm really disappointed there's no ice cream. But I guess you're being healthy with COVID.
I did 2 cookies this time instead. So.
All right. Yeah, that COVID grind. You don't need that.
I do have a question.
Yeah.
Is there any way at some point, I guess, like you could bring a case as well, just like an acute ankle sprain?
Mm-hmm.
We see that all the time, like here. And I know like Alex and stuff like that. Like we've been asked, like people come and ask us to look at it. Like they want us to look at it. And it's like, I don't know where to start. And it kind of just pisses you off.
Yeah.
Because like I always see like, I guess like it's hard because I see it at Winchester. So like when I go with Taylor and I watch him do stuff, like they have BFR. I don't have that machine just like readily available. Like boom, let's just throw BFR on you real quick. Like, I don't know, like it's like, what is like the initial, like if you don't have that type of equipment, like what are you doing to like load it like first week or so out of it happening or something? Like, I don't know.
So blood flow restriction, we don't have them either. The only reason I don't have them, because it's not like it's expensive, it's a time component, which kind of surprised me they use it as much at Winchester as they do. But why do we use BFR? Because you get a growth hormone response, right? IGF-1 response after you flood it back, which is great. But like, how else can you do that? Isometric loading, heavy weights from an isometric standpoint, doesn't have to even be. So think about what they're doing with the BFR band, especially acute phase. It's not a whole lot, right? Like small single leg deadlifts, single leg squats. Maybe they'll do some pumping of the ankle. They'd probably do some sort of calf raise if they can stand it. But like, that's not like, let's say it's a true ATFL injury, right? Lateral ankle sprain. Well, how in the world is that stuff specifically loading the tissue that's been under duress or stressed or, pathologized? It's not. So what we could also say is, well, a really good way to do that, besides getting fancy, is pick up really heavy shit and do isometric holds, right? Mildly load the tissue, keep it moving, make sure fluid's moving through there. And that's what, a side-by-side comparison study would be great on, like heavy isometric loading of the exact same movements, right? Versus BFR with like body weight. And I think that's where... Oh, go ahead.
So isometrically loading into inversion?
No, that's what I'm saying. So maybe I'm wrong. I highly doubt that they're doing like ankle inversions and butterfly squats with a BFR band on, right? It's probably like bilateral squatting and stuff like that. So it's easy.
And then they first start them off with like 3 minutes or plus of like just DNS hanging, and he just challenges them in different positions, like while he's getting fatigued, and then kind of starts them off like doing like lunges. He'll do like some stuff of like I guess later stages, he's doing like a trap bar, like jump, like he's got a trap bar and he's just like jumping with him. Also has him doing like sled pushes with it on. So I guess that's also taking a component of loading it heavy and also doing BFR at the same time, kind of a double whammy.
So isometric is huge because why? So yeah, there are ligaments in the ankle, but let's say, ankle sprain is kind of tough because it is ligament. Also, the research on BFR with ligaments isn't awesome, right? That's like, it's why it's kind of interesting, but let's say tendon, just for this case. So let's say it's a patellar tendinopathy, which would be another common one to use BFR with, right? And I know we're talking about ankle sprains, but you would get more bang for your buck with heavy isometric loading because the tendon is continually stretching against a continually contracting muscle. So the load properties are being altered, as well as growth hormone, IGF-1, prostaglandins, all that stuff, right? Because you can't go as heavy with BFR. I guess you could, but like you're going to get less sets, less time, especially if it's isometric. So I don't know. I like to see a side-by-side. Maybe it exists and I need to go find it. But speaking of ankle sprains in general, if we're talking lateral ankle sprains, ATFL, my postulation would be, like Alex said, like, what's the grade of the sprain, right? Grade 1, grade 2, we do want to start loading that tissue specifically day 1. I don't need a BFR band to do that. And I don't know how much that helps. So that's where like you have to load inversion pretty soon. Obviously get grade 2, grade 3, like you're beyond that, right? If you're not going to have surgery, you have to establish stabilization in other ways, right? Which is, DNS hanging, things like that. But literally that silly bulletproof ankles video on YouTube that I put out is almost identical to what I would do as somebody in the clinic, right? Ankle card. But
honestly, I just sent that to like 3 people.
And I mean, it's fundamental because that's what you need to be able to do. Again, BFR stuff, realize that if you can make something harder, it's perceived as harder too. And I know, obviously I love Winchester and those guys, but I don't know if the science would support that versus something else as being better. It's good for sure. I just don't know if it's better, and if you don't have one, like obviously that's not your option. So what is the next best option? Really heavy loading isometrically. So if I have an ankle sprain, the 2 or 3 things I could do isometrically that would be really heavy would be a single leg deadlift, right? I'm talking like heavy, like 125 pounds just hanging off them there isometrically, trying to hold that for 45 seconds. Split squat, right? Where you're lifting and you're trying to drive your knee as far forward as you could, right? Maybe play with angles on that split squat instead of just a perfect split squat. And then it would be a lateral lunge, right? So your ankle's still technically neutral, so you're not inverted. You take them out of the lateral lunge, try to load the lateral kind of column. You do that and load those things up heavy. It doesn't have to be isometric. Give them heavy weight. You move around, right? And if it's not tolerated well, in isometrics where you go, because now it isn't going to hurt. That's what I would do. Especially, we see traumatic ones all the time with trail runners, obviously. And it's really, for me also, why'd you get the ankle sprain in the first place? Probably because your foot sucks, right? You either got a stiff foot or a sloppy foot. So if I fix that or work on that while I'm working on the ankle sprain, it's probably way better anyways. Does that help at all? Maybe. Like I said, I would love to play around with BFR. I also would like to look at the research. I just think I don't see me putting BFR on like 3 patients a day. If I had trainers, that's where I'd want them to do it. Like when we have a gym, I'll 100% be like, hey, this person's got a little patellar tendinopathy. Like, at the end of their workout, I want you to load them up with this. So like,
yeah, he does. I know Taylor does it a lot, but he also utilizes his interns and stuff like that a ton. Like, I think that's how why they can get it out so fast is like, he sees a patient every 15, 20 minutes.
Yeah.
But like he sees them for the initial like 5 or 10 minutes, and then he sends them off for like 8 to 10 minutes of BFR with the intern or whatever.
Yeah. So if you could do
but
that.
Their big one is they have that one kid that he's a senior for basketball. I'm sure you might have heard of it.
He was there.
The ATFL.
Yeah, he was there Saturday of the R2P thing. Or Sunday or Saturday, yeah.
Yeah. So they were talking about like how he got him back playing with no ankle brace, no nothing in 2 weeks after, coming in, like both ligaments gone and stuff like that. he also wanted me to look at, I guess, too, like the peroneus muscles, looking to see how those compensated for like the lack of the ligaments there. Like every time we're in there, I guess looking to see how, if you don't have those ligaments there, how you had to strengthen those muscles and tendons to be able to take the load, I guess.
And really, that's, again, like those do need to be able to take the load, but like, what's your biggest offset is not going into uncontrolled inversion in the first place, which would be highly regulated by your foot. You know, so I think that's where, yeah, you bolster those, but like, is your foot as good as it could be? No, I mean, obviously I know, you know, Taylor's working on that stuff, but like, is it mobile where it needs to be? And then can you control it where it needs to be controlled? And that's probably like every ankle sprain I've ever seen is some component of that besides just pure trauma, right? Like jumping off something. But if you're running or basketball or whatever, like there's a component of your foot sucks, or the shoe that your foot was in sucks. I mean, I just don't think that exists without that. So you get trauma for sure. Any other questions, guys? And I am recording this one. I'll put this one out and then we'll announce at the end of this. We may not put these out anymore. We'll see. Maybe I'll just wait a long time. I'll put them out like at the end of like 2 weeks after. So people really want to come or something. All right. Well, I appreciate you guys being on here. Oh, go ahead.
So if we need a live ankle case, we can chat up Isaac next time. Yeah. He absolutely destroyed that ATFL, man. Yeah.
How long did you do that?
I'm talking like maybe a month now. Dorsal of the foot and lateral, like whole thing was blackened.
What was he doing?
So the thing is,
Basketball.
He
actually didn't do the like his ankle, like his was weird. So he said he like went up and over like forward. So it's like halfway down his foot, kind of like, I guess almost cuboid area.
Yeah.
Like right around there is like where there's like a big hump. And he said like that's where he hurts, like when you touch it.
Yeah.
only that one spot.
Only that one spot. Like there's nothing in his ankle. Yeah.
He's like right there.
Yeah.
And that's kind of over like middle cuneiform or off to the lateral side? Oh, you're on mute, Alex.
Oh, geez.
Yeah. He's saying like it's a little more like medial than cuboid, but it's like it's over on that side. Like
so
more down his foot.
So the dorsal nerve of your foot runs right over where like the top of your dome of your foot would go, right? If you stress the hell out of that thing, right? Just like if somebody like trips and falls and like extends their leg and gets like a neurodynamic like sciatic stretch, like that's probably what he's dealing with. And that's where like Guy Voyer's stuff, like joint pumping and like fascial work around there can like be huge. And that's kind of, I've seen that enough times just with like lace bite stuff, people tying their shoes really tight. And then that's what's bugging them is that same area. Which did you guys watch the MPI virtual symposium? Tom Michaud talked about that exactly. Like talked about that spot on people's foot. And if they show up with pain and that you can almost do like a Tenel sign. So that'd be one thing for you guys to test on Isaac. To like Tenel it. And if he's like, man, I feel that down under my web, or I like get a little zing, like that's how you can start to rule in nerve versus, tissue. Cause the likelihood of him getting a specific extensor tendon strain is like, I don't know how low that is, but probably pretty low. So barring anything weird, I would look at neurology on that one. All right. Well, yeah, maybe we'll get him to get his foot up in this video next time and we can do that live and talk about a Cripps foot. There'll just be a whole ankle foot night. All right. Well, I'm gonna get off here. It's 8:15. Again, appreciate you guys being on here. Have a good night. Get over COVID. Don't give it to anybody else. Go get your shots or don't. Do whatever you want to do, you hippies.
I mean, I guess we can't get the shot anytime soon because we will mount a huge response.
Yeah.
Just
have a huge cytokine storm and have all sorts of autoimmune flying. Yeah.
That's it. I'm just trying to race. All right.
There you go. All right. Well, do take care of yourselves, guys. I'll see you guys next time. Later.
Good, Bo. See you.